Good afternoon, everyone. Welcome to our discussion. My name is Danielle McCamey, and I'm currently a nurse practitioner in the surgical ICU at MedStar Washington Hospital Center, and I'm also the chief advanced practice provider of pre-anesthesia testing. And I wanted to go over a brief discussion about cultural norms, death and dying in the United States. I have no disclosures. Going over the objectives, today we'll define cultural norms, explore the evolution of death and dying in the United States, discuss clinical, and have an opportunity to share our clinical experiences with cultural norms and how they've influenced death and dying in our clinical practices. So just in brief, cultural norms are systems of beliefs and practices of a cultural group. They influence daily living, moral behavior, and give meaning to life, provide a sense of integrity and belonging. Cultural norms influence health and illness, and norms vary widely across cultural groups. Just some visual representation of words that make us ponder about cultural norms, behaviors, values, rituals, superstitions, standards, backgrounds, ethnicities, habits. So cultural norms influencing death and dying. Here is some visual representation of back in the day, is what I like to call it. So as we all know, back in the 1900s plus, everyone tended to die at home, surrounded by loved ones, and from various diseases. And so this is what the picture was back then. Now, current day, and this is what I'm most exposed to being in the surgical ICU, patients are dying alone with medical providers around them. Oops, sorry. And with the influx of technologies that have either gotten them to this point of prolonging their death. So dying in America has changed. It was once more of a community religious event centered around family, was basically accepted hand-in-hand alongside with birth. And lots of family were involved in the process and was more acceptable. It's become so medicalized, it's viewed as failure, and people are frequently dying at institutions. And it's become something more that we as Americans tend to avoid. So is the tide really changing? Majority of Americans would like to die at home, but the reality is they aren't. Most are dying in acute care hospitals, some are dying in nursing homes, and only a small fraction are dying at home. And a minority of patients are using hospice care, but most likely are being referred during the last couple of weeks of life. So I've got a question for you. These discussions are usually more enriched when we have an opportunity to share our own personal clinical experiences. So I just wanted to open it up for anyone to share some cultural norms that you've experienced in your clinical practice that have influenced the death and dying process. It could be simple.
We have to do everything.
Yeah. Yep. I've experienced that a lot in the SICU. We're waiting on a miracle. Let nature take its course, even though they're intubated, sedated on CVVH, maxed out on multiple drips.
And TV really distorted people's idea of how one should die.
That's a good one.
People get scared with the gasping, because TV make it really clean.
That's true.
And silent and peaceful most of the time, or it's the other extreme.
Yes, in the back.
I'm from inner city Flint, Michigan, and we have a large Afro-American population. And one of the things that I see almost on a daily basis is when presented with a hopeless situation, there's such distrust of the medical community that the Afro-American population that I deal with absolutely will not allow us to let patients die in peace or die with some dignity.
That's a good one, the distrust. Yes, sorry, go ahead.
There's a large component of faith, or even presented as evidence, is well that we're going to put our faith in a higher power and
Mm-hmm.
trust in that.
Yeah, go ahead.
Many of the patients, I'm retired now, but work in Washington D.C. Many of the patients are, even when the families are in agreement, they're usually unwilling to make that decision. And, they say, talk about God's will, and are much more willing to allow, unfortunately, them to die in an ICU or a hospital setting than making the decision, quote unquote, as I've heard some people vilify their relatives who killed their relative because they let them be sent into a hospice or allowed them, or took them off the ventilator.
Yeah, pulling the plug.
And the population I served was 90-some% African American.
Yeah. Yes.
I'm in pediatrics, and I don't
Oh.
see it much different.
Really?
Most of the kids that we have who die in pediatrics do die in hospital, but I don't see that that's changing.
Anyone else?
Certainly it's related to educational level, right?
Definitely.
And less educated watch television and where whatever 80% of people's lives, CPR, and occasionally it's very hard to know. The younger family wants to check
Mm.
for caring for the elderly patient. They want the money, they're not really concerned about their family. But that's very hard to know sometimes.
Right.
What motivates?
Dr. Johnson?
I think there's some very interesting cultural norms in medicine about what happens around the time of death. I mean, first of all, there's this idea that it's somehow a battle, which I think people are starting to write about now, and about how it's us versus death, and as us as medical providers. And so this idea that we lose every time a patient dies is, I think, still pervasive in medical care and the culture of medicine. And yet, interestingly enough, I tend to see that the people who are around to deal with death and dying are the trainees. Like the physicians, the attendings don't come in to pronounce their patients at a teaching institution, and they're very rarely actively involved in that portion of the process. And so we're leaving people who are the least prepared to deal with the implications of this to suddenly figure out, like, what am I supposed to do? This patient just died, the family is, grieving in whatever fashion they're grieving, and my attending has pieced out. So clearly that needs to be okay for me to piece out when I'm the physician in charge. So, and I think maybe some of our patients' responses to death in the hospital is because of that piecing out of the medical practitioners
Mm-hmm.
culturally over time. So.
Yes.
One thing I've noticed, I'm a pulmonary physician and work in the ICU, but even when they're in the hospital, I hate to point away from myself, but, they're not adequately prepared by the team on the floor. The issue is usually not brought up.
Mm-hmm.
When they deteriorate, they say, well, we're going to send them to the ICU. So we have responsibilities at all levels of this. And certainly there's a responsibility in the office. If you're seeing patients on a regular basis, many times that's not discussed.
Mm-hmm. Good point. And just to piggyback off of Dr. Johnson, I mean, looking at the culture between providers from even specialties from SICU and MICU, they tend to handle death and dying in the hospital a little bit different. SICU, we're all about the technology, if we can cut, we can cure. And sometimes the MICU team seems to be a little bit more proactive in looking at quality and how can we get the family more involved? How can we educate the family about what the dying process is going to look like once the medical technologies have met their needs, but the body is kind of surpassing that. So, So thank you for sharing.